All right, let's finish up with tubulointerstitial diseases. Okay. A little bit going over the clinical manifestations of this disease processes. We'll talk about the mechanical tubular interstitial injury, and then also cyst formation results in failure. The anatomic location of this area is now beyond the glomerulocapillary and Bowman's capsule. Now you're talking about proximal tubules, anything on the loop of Henle, distal convoluted tubules, and collecting ducts. Any part of these can be part of the tubulointerstitial disease process. Okay. The clinical manifestations is that urine sediment is active in disorders that are characterized by acute inflammation, and that is occurring because you're actually damaging the actual tubule itself, and you start getting basically apoptosis taking place. Things like acute interstitial nephritis, acute pyelonephritis, or infections of the kidney itself. Okay, you do see white cell cast form because it's an intrinsic renal disease process, and you can also get things like marked hematuria and red blood cell cast, but they're more rare in TI disorders. These are, if you see hematuria and red blood cell cast, you're really seeing a problem where? It's in the glomerulus. Okay, it's in the glomerulus that the damage is taking place. So in tubulointerstitial injury, you're not going to really see a lot of red blood cells. You can see more of an inflammation or granular cast or white cell cast unless you have a glomerular tubulointerstitial disease process, which is something that's a little bit more difficult to manage at times. You can get things like acute toxic tubulopathies that are characterized by degeneration of the tubular cells. A typical example is aminoglycoside toxicity. The other one is acyclovir toxicity. If you take care of somebody that has this problem, you'll notice that your urine before was yellow and nice and clear, and then all of a sudden you'll start seeing sediments form inside the ureter, and that's actually your nephrons. Portions of the proximal tubule are now being deposited now into the actual, and the more you see, the more damaged kidney you're looking at. Okay. You can also have chronic tubulointerstitial diseases where urine sediment can actually be inactive because the chronic disease process is now developing the next stage, which is fibrosis and sclerosis, which is damaging the nephron, scarification is taking place, and what you see as progression gets worse and worse, it becomes the person will start developing proteinuria, and the worsening the proteinuria indicates a worsening glomerular disease process. Now, again, the question is, why does it go to that? Why does it, the book is not clear about this. It talks about how it's chronic initially, but then it becomes progressive by proteinuria. Why? See, nobody got that when they read the text. Okay? I didn't either when I read it the first time, so I'm going to be fair about it, okay? What happens in this situation is that you continue damaging individual nephrons. And what you're left with is the only ones that are going to work are limited. You have, instead of having 100, let's say you're down to 10. Well, the 10 are also going to get more and more blood flow to them. It's like the single nephron discussion we had before. So as a consequence with time, the glomeruli capillaries will get damaged, and they will show signs of proteinuria at that point, which means at that point that you've got so much damage in the kidney that the glomerulus now start to show signs of damage as well. That's a very bad progression of the disease. Things that can also cause tubulointerstitial injuries are things that reflux into the kidney. So bacterial infections can become really terrible. And we call those nephritises. Okay? We call them inflammation of the kidney. And you can tell the difference between a urinary tract infection, because urinary tract infection, when you tap somebody in the back, which is you hit them right here, they don't jump. They'll hurt a little bit, but they won't jump right off the bed. Versus somebody who has true acute pyelonephritis, okay, when you tap them on the back, they literally jump because of the inflammation in the kidney. The kidney can't really swell too much because it's covered by what's called Girott's fascia, which is a pretty tight, very strong fascia. So when you get that kind of inflammation, the kidney gets pretty angry and it's extremely sensitive to pain. Okay? So that's how you know you have now converted that person into a UTI, into an acute pyelonephritis. Now there's two kinds of urinary tract infections. There's things that can be caused by poor hygiene. It could be from a stone that's become infected. It could be that the person has prostate infection, has had some kind of urethritis, which is the urethra is inflamed and caused by some kind of infection as well. So it could be GC. It could be a number of things, okay? And it progresses from below up, okay? It's called ascending. Or it could have a descending UTI, which is bad because at that point the bacteria are coming from the bloodstream, going through the glomerulus, getting into your urine, and that means you're going to get infection of the kidney usually at the same time. Okay? Usually most people, actually about 10% of people that have UTIs don't even know they have them. Okay? They don't have very minimal symptoms, but they're walking around with a chronic urinary tract infection. Okay? You can also have things that can also damage besides bacteria or reflux nephropathy, which I'll show you a picture of that in a minute, usually seen in children. Then you're going to have drug-induced hypersensitivity, intratubular obstruction, urinary tract obstruction, and cyst formation. Bacterial infections are pyelonephritis is infection of the kidney tubules. It's usually due to gram-negative bacilli from patient's own flora, which means that most infections are coming from below up. They're ascending. Okay? Usually it's a woman. The reason being is not the women are any different in the sense that they're not as clean or anything like that, because people sometimes will say that's not the case. It's that they have different kind of anatomy, and the urethra is very short in a woman. Okay? The other thing that the women have a very definite disadvantage is that they don't have a prostate gland. And the prostate gland in the man produces a secretion into the urethra that basically prevents bacteria from going up into the bladder. Women don't have that. So as a consequence, any kind of bacteria that can enter into the urethra has a very strong possibility for a short distance, especially as a flagellated organism like E. coli, to get into the bladder. So women have a much higher frequency of developing UTIs. If you see a man get a UTI, he has something pathologically wrong. Okay? Very different. Versus a woman gets a UTI, you just treat it and don't think about it. But if a man gets in a UTI, you got to think something pathologically is wrong. Prostate cancer, you might have prostatitis, you might have some kind of sexually transmitted disease. You've got to start thinking that if a man gets UTI, it's serious. Women still have a very discomfort of the UTI, but you're usually much more easily treated, and usually you indicate to them proper hygiene, and it usually takes it away. And sometimes it's also, one of the things that we see a lot of is women, when they get married, they're usually called honeymoon UTI. Within 30 days of getting married, they have a bad significant UTI. And again, this is the kind of things you need to instruct people on how to proper hygiene so they don't get these kind of recurring infections. And sometimes it could be that the male has an infection that he doesn't know about and he's transmitting it to the woman. And they need to figure that out as well, because otherwise you're going to have that patient keep coming back. The other thing that you'll get the bacterial is descending, which is hematogenous. The ascending is by far the most common one. Women are higher risk. This is why I was telling you about. The other thing that's also makes the women at higher risk is their hormonal changes. It promotes bacterial adherence and urethral trauma during intercourse. The other thing you can also cause for bladder infections in both males or females is vesicoureteral reflux, which is a congenital problem where the person does not have proper attachments of the ureters to the actual bladder. And instead of having, when the bladder normally constricts down, the ureters are closed off to the bladder. Okay, so when your bladder, collapses down, it literally closes two doors on both sides and prevents the urine to reflux back. If these people, they don't have that. They don't have the proper arrangement. So as a consequence, when the bladder squeezes down, the ureter gets filled with urine, and it refluxes back up. And that develops what's called a hydroureter, which means that the ureter on one side gets larger than the other, and that's a perfect nidus for an infection. And that's what happens to these kids eventually, and if you don't treat it soon, you end up you lose a kidney, and they have a higher risk of developing end-stage renal disease. So this is what you see with vesicouretic reflux. You see that the actual bladder now is refluxing urine. Instead of going out the urethra, it's going back up the ureter, and it goes back all the way back into the kidneys. One thing that you do see with intrarenal reflux is that it tends to affect the upper and lower poles more so of the kidney. So as a consequence, you get greater scarification there and greater damage in those areas of the kidney. Again, this is more of a picture showing the abnormal anatomy. And this is a hydroureter. This is what we see. And you see the end-stage damage, which is called hydronephrosis, which means that kidney is no longer functional in that individual. Symptoms is usually sudden onset pain. Usually it's a carcinovertebral angle, and it's evidence of systemic infection. This is the acute pyelonephritis. It's an infection of the kidney. So you get systemic infections with fever, malaise. You also get symptoms of bladder urethral irritation. You get severe dysuria, which is pain on urination, frequency and urgency. I don't know if anybody's had a UTI, but it's pretty uncomfortable. Pyuria is you'll see pus in the urine. It's an indication of acute inflammation anywhere in the urinary tract, but it's not specific to pyelonephritis. So you don't, just because you see pus coming out of the person's urethra does not mean that they have it in the actual kidney. But when you see white cell cast, on the other hand, it is indicative of acute pyelonephritis. So one of the things that you do is you draw your urinalysis and you look for cast, and you see white cell cast, and you got now a diagnosis of UTI. Now it's moved up to acute pyelonephritis, which has a much more significant risk factor of going into full-blown sepsis. The number one cause of death in older people from infections consistently is urinary tract infections, acute pyelonephritis. Okay, for lots of reasons. One is they have indwelling colies in. They'll have enlarged prostates. There have lots of reasons why they develop problems. Pathology, you get patchy interstitial suppurative inflammation, the tubular necrosis. Suppuration occurs in discrete focal. You know what suppuration means? It's like a giant abscess inside the kidney. So you'll see pus pockets inside. It's called suppuration. That means that portion of the kidney has died and the cells have necrosed. Not good. Okay? And you'll get focal abscesses. You get wedge-shaped large abscesses if the suppurative foci coalesce. And that's not a good sign, because then what happens to the blood supply to that area? It's not any good, so you can't get the kidneys, the antibiotics to work to that. If you don't have blood flow to the kidney or any kind of infection, if you don't get blood flow to the infection site, it won't work. That's why we actually have to drain these things. Okay? If reflux is a cause, then you basically need to do a reimplantation surgery, which is what we do on children. These are big procedures, not small, and requires a general anesthetic. And these kids tend to do well, but it's not something that it's a small operation. You need to get a special urologist to do that. You also will see neutrophilic infiltrates early, and then you'll see eventually rupturing of the actual tubules themselves and causing extensive damage to the kidney. The reflux nephropathy tends to occur early in life, so it's a congenital, which may be either unilateral or bilateral. Okay, and you need to deal with these quickly. So usually what we try to do is they'll put in stents in to temporize this problem, and then they'll get these kids assigned to a urology specialist to eventually reimplant and make this problem go away. The other thing that can happen besides acute the vesicular reflux disease is you can have acute drug-induced interstitial nephritis, and many different drugs can cause toxemia to actually attack the kidney. Things like penicillin, which most people don't think about, if you give it enough dosage, you can cause renal failure. Sulfonamides are also pretty pathognomonic and non-steroidal anti-inflammatory agents. The actual etiology, we don't really understand why some people have problems in comparison to others, but we think it has to do with a cell-mediated immunity, which means that the person somehow has developed an autoimmune process to that drug, okay, or an immune process to that drug. And then it causes cell-mediated activation, which then causes necrosis that you see. You do see urine sediments that contain white cells and white cell cast. And occasionally you see high amounts of eosinophils, which is more consistent with that cell-mediated immunity we was talking about. And not always do you see the proteinuria. Sometimes may or may not be present. The only time you see that is when the glomerulus is damaged. Okay? Clinical course is usually after exposure to the drug, the person goes into acute renal failure for 1 to 2 weeks after the drug has been given to the individual. And then if you discontinue the drug, most people get better. As of course, as you get older, it becomes more of a problem because your nephron numbers have basically been reduced. So really, the key to this is try to avoid nephrotoxic agents to your patients. You can have the drug-induced tubular injuries can be accumulation of filtered drugs in the proximal tubules. these proximal tubules suffer damage and necrosis. The typical example of this is the analgesic abuse nephropathy. That used to be seen a lot in the 1930s and 1950s, 60s with what's called phenacetin. I'm not sure anybody's here old enough to know what phenacetin is. Has anybody been used phenacetin? It's the same thing as in Vicks Vapor Rub. Okay? It used to be a really good analgesic. The problem with it is that too many people were taking too much of it, and they were developing renal failure with it. In the 1950s, 1940s, dialysis was not available, and a lot of people died. So they finally took it off the market. Okay? Acetaminophen can break down into phenacetin. Okay, and that's why if you overdose on acetaminophen all the time, you can get renal toxic with it. That's what we think. It's unclear if that's a complete mechanism. That's why I put a question mark there. But it's something you got to be aware of. If somebody's telling you that they're doing a lot of Tylenol, you got to worry about the kidneys. You get lesions in the vasa recta and the capillaries, and the focal areas of necrosis causes fibrosis to take place. And usually it depends on the duration. The longer the duration, the more likely you're going to get profound renal problems, and otherwise can become an issue. The next thing is, what else can cause tubulointerstitial disease? And the answer is urinary tract obstructions, and these are mostly due to stones. And the most common one of these stones is calcium, which we'll talk about in a little bit. Where you see this really endemic in certain portions of the world are like the Malaysians. You see that in their fishermen and their soldiers who get chronically dehydrated. They have a very high incidence of developing stones. If you live here in South Florida, the incidence here of stones is extremely high, one of the highest in the United States. Okay? Again, because of chronic dehydration. When I used to work in Chicago, the same thing happened. Everybody used to laugh at me and say, well, why are you giving people that are women that are right before they're going to have an epidural placed for C-section, why are you giving them a liter crystalloid? And I said, well, because otherwise they get hypotensive. And they said, well, you don't have to do that here. Okay. So I didn't do it and watched what happened. Nothing happened. Patients did fine. Came back to South Florida about 2 years later. Decided to try the Chicago way. Boy, did I get burned first day. I learned real quick, everybody down here is dehydrated. Okay, you give them a liter right up front because they're functionally dehydrated. And sure enough, after that, never had a problem again. So you got to know your patient population. The reason the difference is difference in climate, difference in humidity. Even though we live all day long in air conditioning here, the humidity here is high, so you tend to lose volume very quickly here. Males are more common than females having urinary tract obstructions, and we're not sure if that's just genetic differences or hormonal differences, or rather just that people are working out more in the heat. It's really unclear, but the males do have a higher tendency than females. It tends to occur in families, which means that it is genetic. So if your family member has had a stone, you're likely to have a stone yourself. Okay? The 4 types that were calculated that I expect you to memorize for your test is the calcium-containing stones, the most common, 75%. The next one there that was called a triple was called struvite stones, which is around 15%. Uric acid stones account for 6%, and cystine stones account for 1 to 2%. Basically, all these stone formations are due to increased urinary tract concentrations of precipitates. And as a consequence, it begins to supersaturate and starts forming crystals, eventually forming a stone. The calcium oxalate stones are patients that tend to be hypercalcemic and hypercalciuric. So you see calcium in the urine, and you see these nice little things. These look cute, right? Yeah, these cute form into this, like little asteroids. And the nice thing about calcium phosphate stones, which is anything nice about them, is they tear you up as they travel through you, and they make you hemorrhage like crazy. So a lot of these people will come in with frank hematuria as well. Not too bad, but you can still see considerable bleeding. Usually it's associated with hyperparathyroidism, patients with diffuse bone disease, sarcoid, or renal tubular acidosis. I don't expect you to memorize that. If you were an internal medicine doctor, I'd expect you to memorize that, but please don't. Sort of know what the highest percentage of which one and what kind of symptoms you're going to have. Most people are idiopathic, which means that you don't know that they have hypercalciuria, and they maybe have a higher genetic tendency to absorb calcium than others, and that's why they excrete it more in the urine. And about 20% calciums are associated with increased uric acid secretion with or without hypercalciuria. Triple stones are the ones that I worry about the most. They're made up of 3 different components: magnesium, ammonium, and phosphate. The reason they're so nasty is that because they're formed from infections. They're formed from what's called urea-splitting bacteria. The most common of these are staph and proteus, proteus being by number 1, which converts urea to ammonia. And then ammonia then binds to the magnesium and the phosphate and forms these really, really, really large stones. Okay? Especially it results in an alkaline urine, causes the precipitation of this to occur more rapidly. The stones are usually very large, and they develop into what's called staghorn calculi. Why staghorn? Well, because they look like the horns and a stag, which is a deer. Okay, so I'll show you a picture of it in a minute. And this is a real problem because these stones don't travel down the ureter, so you can't get rid of it. It basically sits in the calyx. So what does it look like? This is the X-ray of it. You can see how big the stone is. Okay, and this is what it looks like when you took out the kidney. And the kidney died because this stone filled up the calyx so much so that urine couldn't come out. Pretty devastating complication. Okay, so how do you get rid of this stuff? And that's where it becomes a real problem. One, it's a chronic urinary tract infection. So you want to treat the infection if you can. But what happens with this crystallization? What's embedded in it, you think? They just built themselves an apartment, and they're living inside the apartment. The urea-splitting organisms are in very high concentrations inside this stone. So unless you get rid of the stone, you're never going to get rid of the infection. Okay? It's that simple. So what was done nowadays is that we flip the patient into a prone position. Personally, the way I look at this, if you put a patient in a prone position and then you're going to irrigate 5 to 7 liters of crystalloid, or even up to 20 liters of crystalloid into their back, into this pelvic area, into the calyx, then you should invasively monitor them. So I put an A-line in all my patients that have this procedure, period. Some people don't do that. I think it's foolish. Okay? But I do it for every single one of my patients that are having this done. Because what will happen is when they infuse the liquid into this space, if that liquid infuses into the interstitial space and gets absorbed in a highly vascular tissue, this person can get severely hyponatremic and code on you. Okay, so you got to watch your ins and outs. So when you work in these rooms, you'll find out that there's a whole protocol. That protocol was developed to a certain degree by me, so you'll drive you crazy. Sorry. It's to make you watch that you're putting in what you're getting out. There was one case here where they infused over 70 liters of fluid supposedly, and they actually got into the patient almost 10 liters, and the patient passed, did not make it. So you really got to watch. What they do is they break up these stones as they get into the calyx with lasers and also by ultrasound devices that break it up, and then they pull the pieces out one piece by grasping it. So this is not a short procedure, is what I'm trying to tell you. Okay? This will take several hours. And I think they really do deserve invasive monitoring and close watching. The next stone is uric acid stones. This is usually only seen in gout, so it's hyperuricemia. It's disease involving rapid turnover of cells. Remember, these are this is uric acid, breakdown of an acid. What's the only acid you have in your body? Well, not really an acid, but I mean, it's what component is making up an acid, we always call it. It could be amino acids, but it's not. Amino acids is urea. What's the other one? Deoxyribonucleic acid and RNA, which is ribonucleic acid. So uric acid is coming from breakdown of DNA and RNA. Okay, so when you have rapidly turning over cells, where cells begin to lyse and release large amount of nuclear components, you can get very high levels of uric acid levels, and that can induce a hyperuricemia. More than half the patients have normal uric acid levels sometimes, but they still concentrate this in the urine. The bad thing about this stone is that it's radiolucent. But it looks pretty, but it does tear you up, but you don't know where it's coming from. When you do the actual dye studies, the only thing it will tell you is you won't see it. You'll just see where the obstruction's at. Okay, so you can't, it's not a radiolucent like one, the calcium. Cystine stones, these are very rare, count for less than 1%. It's of course an autosomal recessive disorder. It results from excessive excretion of 4 basic amino acids called CoLA, which is cysteine, ornithine, lysine, and arginine. And can also be seen in patients without the disease, but I'd say 99% of them is due to the autosomal recessive component. And you can see how many stones you'll find forming in these individuals. They can coalesce and form like a staghorn as well, but they have a very different appearance. And these are not related with infections, so usually not an issue with that. Stones are unilateral in 80% of cases, and they do have their favorite site. They live in the renal calyx. That's where they're concentrating in the renal pelvis and bladder, and also the appearance. As long as they're sitting in your kidney, nothing's going to happen to you. It won't hurt. It won't cause you any problems. But unless it completely obstructs your calyx, which is what the staghorn caculi do. But otherwise, if it's sitting there and you do an X-ray and the stone is sitting in your kidney, you don't have to do anything. You have to leave it alone. The only time we do anything is when the stone moves and goes into the ureter. When it goes into the ureter, that's when it becomes a problem. If it can completely obstruct your ureter, then you can have acute hydronephrosis on that side, and the kidney can fail on that side. So one of the things you want to do is you put in a stent in those individuals to relieve that pressure. So they require to go to the operating room immediately. The danger to them is that when you come ascendingly, when you're coming from the below and up, if you have a UTI and you open up the stent and the stent becomes infected, now the bacteria gets seeded, and the increased hydronephrosis already has opened up the vasculature inside the kidney, and the kidney can then absorb that bacteria quickly, and the person can go in profound uroseptic shock on you in the operating room. And I've seen that happen several times. And of course, what's going to be blamed? It's the anesthetic that's doing it. Yeah, right. Fever goes from zero, normal. All of a sudden, you got a hypothermic patient, hypertensive, shocky. And the surgeon's working down from below. It's mostly a urosepsis you're looking at. Obstruct urinary flow, pain, bleeding due to ulceration. Small stones are more hazardous than large ones because they tend to they want to stick versus a large stone stain the calyx. And can be asymptomatic, but unless it becomes obstructive, and also can cause hematuria, which we talked to you about before. The other thing that can happen, it also cause interstitial tubular disease, is things called intratubular obstructions, like things like myeloma kidney. This is could be from sloughing of cells and debris from the ATN, or it could be from precipitation of filtration that occurs from things that are produced in excessive amounts. One of these is multiple myeloma, where the person has a kind of cancer that is very high amounts of plasma cells that are producing a very high concentration of antibodies. These antibodies then are filtered in excessive amounts in the kidney and then obstructs the actual the interstitial space. This is what you get from the intratubular obstruction. You'll see the normal lumen, then you'll see the denuding of the cells, and you get complete obstruction of the process. And the last one to talk about is cyst formation. I'm not going to get into the pathophysiology of that too much. Just to understand that if you get a cyst formation, guess what happens to kidney function? It stops. It's that simple. Cysts don't make the kidney work. Okay? Just because it's got a bigger lumen does not mean that it can actually filter better. It doesn't work that way. Okay? So when you get polycystic disease like this person's kidney is basically dysfunctional and they require dialysis. This is one of the few cases where we actually have to go in and take the kidneys out before we put the new kidney in. The reason being is it becomes so enlarged inside into the retroperitoneum that it becomes very uncomfortable, and these people develop chronic pain syndromes. So these people actually will require a nephrectomy, sometimes even a bilateral nephrectomy, to get this polycystic kidney out, and then it's followed by putting in a transplanted kidney later on. Okay? That's it for today. Any questions?